There we go.
That should work.
Yeah.
Mute this up.
Yeah.
Because I can hear myself.
Yeah.
It's a little weird. Cool. Should I just get started? Okay. A scintillating crowd today. All right, guys, so we'll get started. My name is Gilani, and I'll be talking about using heated high flow in management of hypoxic respiratory failure. No conflict of interest. So our objectives today is to review physiologic effects of heated high flow on respiratory mechanics, some clinically relevant outcomes, some special patient populations, and I also wanted to take a look at heated high flow in COVID-19. I know we've been using that quite frequently. There is some data to support that, that use as well. So let's start off with a case study. So we have an 85-year-old gentleman who's a retired pulmonologist. Of course, he comes in on a green shift for hypoxic failure, which is related to pneumonia. He needs more support, but he's refusing his heated high flow because he shouts at you and says, I was a pulmonologist while you were still in diapers, and I don't trust your new toys. Apparently, heated high flow is a new toy for him. So now you're unsure if he's delirious from hypoxia or a cranky old man, but you decide to pull out some literature for him. You have time for that on green shifts, right, guys? So basically what a heated high flow system is, it's a very simple device. It has soft nasal prongs, a humidifier, a FiO2 blender, and a flow rate blender. And those are the main components of a heated high flow system. The small pliable prongs are very comfortable for patients, and the heat and humidification that the system provides does help with mucus clearance and decreased work of breathing as well. We'll talk a little bit about washout of dead space, the PEEP effect, and the flow rate being high can actually match flow demands for a patient at hypoxic failure. So this was elegantly shown by a paper published in 1985 in which respiratory models were created, and they used tagged krypton as gas in lieu of CO2. And what they had done was they had put heated high flow at 45 liters. And what the study showed was that just the application of heated high flow helped to wash out the dead space in the upper airways and in the nasal pharynx very quickly. This was within a couple minutes. And this is one of the theories behind why heated high flow helps to reduce respiratory demand, is that we're able to wash out some of the CO2 and decrease some of that dead space. Now the PEEP effect, this was shown by the Park group. The PEEP effect is actually flow, related to flow. So what they found was that a flow of about 50 liters per minute or so does apply about 4.8 centimeters of water of PEEP. And that's kind of our practice as well. And again, that's related to flow. Now, some of the respiratory mechanics themselves, this was actually a single center trial. They used 15 patients with severe ARDS. And they used an esophageal balloon. The study had an interesting design because they used the patients as their own self-control. What they'd done was they gave them 20 minutes of face mask, made the calculations, and then applied heated high flow at 40 liters and made those same calculations to see what difference that made. And they used the same or similar FiO2. So basically what they found was that in comparison to these two modalities, you had improved oxygenation, lowered respiratory rate, lowered work of breathing, increased end expiratory lung volume related to the PEEP effect, and improved lung compliance as well. The same group used 17 patients, again with a interesting study design with self-control. And in this in this study, they wanted to see what effect increasing flow rates had on these lung parameters. And what they found was that increasing flow rates had a linear improvement in respiratory rate and effort, and also lung mechanics as well. However, they did note that optimum flow did not always equal the highest flow for all patients. That's related to matching their demand needs. And of course, that 85-year-old pulmonologist was myself, 50 years in the future. And I told the fellow that I prefer meta-analyses. So we'll take a look. Cochrane Review actually published recently, it was in 21, I believe. They compared 31 studies, and these were all ICU patients with acute hypoxic respiratory failure. They compared heated high flow with conventional oxygen therapy, which is a face mask or nasal cannula, and BiPAP as well. So what we found was that conventional oxygen therapy versus heated high flow did have an improvement in PaO2 and also decreased the progression to needing intubation. And when they compared, and there was no difference in mortality, when they compared heated high flow to non-invasive BiPAP, no difference in mortality was noted, and the rates of nosocomial pneumonia were similar as well. There was a concern early on during when heated high flow was first coming about that it may induce more nosocomial pneumonia related to the increased flows through the nose. So that's why they made a mention of that. So let's just take a look at some of the data. So comparing heated high flow to non-invasive ventilation, you had quicker improvement in respiratory rate. And you also had, and similarly, they wanted to take a look at the PF ratio. This, however, you were able to improve quicker using traditional BiPAP. And that kind of makes sense intuitively as well, because you can utilize a lot higher pressure to overcome that. Now, comfort-wise, I think intuitively we know this as well, that heated high flow nasal cannula is much more comfortable than the BiPAP mask. And you have some data to support that as well. Now, in terms of mortality, unfortunately, there was no difference between heated high flow and non-invasive ventilation. And so this was from the Cochrane Review. A different set of data was utilized for this meta-analyses, and they found the same, that there was no difference in mortality. So this has been validated quite recently. Now, the risk of intubation, however, that same group took a look at comparing standard oxygen therapy to heated high flow. And there was actually, or favoring heated high flow over conventional oxygen therapy for hypoxic failure. And the number needed to treat was actually 23. So you can reduce the risk of intubation using heated high flow. And this is something that we see quite frequently as well, especially with COVID-19 nowadays. Now, another set of data that was recently published wanted to compare heated high flow with non-invasive ventilation. And there was a slight favoring of heated high flow over non-invasive ventilation for progression to intubation. Now, they summarize, or they theorize on why that could be. One could be related to self-induced lung injury when we do use higher pressures on non-invasive ventilation. However, they weren't really able to tease out why this mechanism exists, but we do have data to support heated high flow over non-invasive ventilation, at least for the risk of intubation. So let's look at some special patient populations, because the question arrives on what the etiology of your hypoxic respiratory failure is. So this group took a look at some registry data from Korea. And what they wanted to see was there a difference in using heated high flow in ARDS related to pneumonia or non-pneumonia ARDS? And what they found was that there was no real differences in the need for mechanical ventilation, mortality, or heated high flow failure rates when we compared the two etiologies. And at the bottom, you can see what kind of patient population group that we're looking at. That we're looking at fairly severe ARDS with sepsis as well, with lactates greater than 4 in a majority of patients. So this becomes applicable to our patient population. So this is a small study from Spain that looked at 50 or so patients with bilateral lung transplantation, approximately 200 days out from their transplant. And they wanted to see if conventional oxygen therapy versus heated high flow, if there's a difference in the need for mechanical ventilation. And they did find that using heated high flow, you do decrease the risk of mechanical ventilation in these patients as well, with no increase in mortality. So this kind of data does show that we can use heated high flow for patients who have had lung transplants. Now, another group wanted to take a look at whether heated high flow is safe for immunocompromised patients. Again, this question came about related to having high flow rates through the respiratory system, driving down some bacteria, causing nosocomial pneumonia. And this is a meta-analysis that this group published with no increased risk in the infection rate. So it was deemed to be safe to be utilized in immunocompromised patients as well. Now, another group from Italy took a look at heated high flow uses in PE-related hypoxia. And this was a small study. I'm forgetting the exact patient population that they had used. But what they had found was that once heated high flow was initiated, you had a decrease in your respiratory rate, increase in your pulse ox, and maintain your MAP as well. And you had a decrease in your heart rate. So you had very stable hemodynamic parameters after utilizing heated high flow in these patients. So now this group had taken a look at using heated high flow for severe ARDS. And this was one of the only groups that had actually found a mortality benefit, but the level of evidence was a little suspect. When we put it into meta-analysis, we find that that mortality difference does not exist. However, what they had found here was that in severe ARDS, the risk of intubation was actually the lowest for people who were on heated high flow as compared to people who were on non-invasive ventilation. And what they had theorized was that this was related to self-induced lung injury from the severe ARDS. Some of the adverse effects that we have noticed when using heated high flow, apparently it's in the name, it's hot. So people feel hot. But that was really the only major adverse effect. There were no hemodynamic effects that were found. Now, whenever we talk about utilizing heated high flow, and as pulmonologists, we intuitively do this in our head when we're evaluating if people are being successful or not on their heated high flow therapy, or do they need further mechanical ventilation. However, this group, I believe from Italy, created what we call the ROX index. And if you read heated high flow literature, this term comes about very frequently. So what they've done is they've taken the inverse. So they've taken pulse ox over FiO2, and they divided that by the respiratory rate to come up with this ratio. What they found was that if we measured the ROX index at the 12-hour mark from the initiation of therapy, and if that number was 4.88 or above, that usually tended to be successful in the sense that you did not need to utilize mechanical ventilation for those patients. If that ROX index at 12 hours was below 4.88, there was a high risk of needing intubation in the future. Again, like I mentioned, this is something that we kind of intuitively do anyway. I don't think anyone really calculates out this ratio at bedside, but it is a tool. I don't know, Guizal is looking at me, so I'm assuming that he does, but the other thing that they found was that the mortality increase from the delay of intubation was very similar, 48 hours onwards. So they theorize that you can use this data to show that there is not a increased mortality 48 hours after initiation of heated high flow if you needed to intubate someone. Now, there's been some literature also published about utilizing heated high flow in the post-extubation phase as well, instead of nasal cannula like we typically do. This was a multi-centered randomized controlled trial published in 2016, in which they had randomized patients into the heated high flow versus conventional oxygen therapy after a planned extubation for a total of 72 hours. And they had applied heated high flow regardless of their hypoxia status. So they had extubated people when they met criteria, and they put on either nasal cannula or a heated high flow. So when we compared the two groups, we had a significantly decreased need for mechanical ventilation in the heated high flow group. So something to consider when we're doing standard extubation criteria. More recently, this was a study published in China, and what they were looking at was the utilization of heated high flow nasal cannula versus non-invasive ventilation in patients with hypercarbic respiratory failure. I know this talk is more about hypoxic respiratory failure, but I just wanted to make a note of this, that there is some data that exists to help support heated high flow use in patients who are extubated after COPD exacerbation. What they had done was, this was set up as a non-inferiority study where they used a risk of, or inferiority margin of 9% difference. And what they found was that our treatment failure difference was 6%. So they said that heated high flow compared to non-invasive is non-inferior. So what that means for us is, if patients are intolerant of their non-invasive ventilation after extubation, heated high flow may be something that we can utilize. And taking a look at some of the other data that they had published, what we're looking at here is what we consider important is the pH and PCO2 after extubation. So we can take a look that both in the non-invasive ventilation and the heated high flow group, we did not have a significant increase in the hypercarbia, and this is up to 48 hours. And they use the 48 hours mark because that's their traditional MICU discharge time. So something to consider. Now, the ACP actually recommends using high flow nasal cannula over non-invasive ventilation for patients with acute hypoxic respiratory failure. So there are some guidelines that utilize this concept. Now, let's talk about heated high flow use in COVID-19 hypoxic respiratory failure. I know this is something that we're very familiar with in this group. Actually, I think the patient had COVID, so now he wants COVID data. It's a very annoying patient. So as you guys can imagine, most of this data is retrospective and observational in nature. Very early on in the pandemic, there was a small study that was published out of China of 17 patients, in which they had a 41% heated high flow failure rate requiring intubation. And this is why this became, initially became not the standard of care, and we were going more towards early intubation and such. However, subsequent data has shown that heated high flow can be safely applied to patients with COVID-19 hypoxic respiratory failure. Very small study. This was 5 patients in Italy. I forget. I can look in the telling you the data is not super robust in the COVID-19 realm here. But what this group found was that utilizing heated high flow had an increase in your PaO2, had an improvement in your PF ratio, and had an improvement in your ROX index as well. A little bit larger study. This is from Italy again, 28 patients. And what I've highlighted here for you is that in all cases, or in the success group versus failure group, utilizing heated high flow, there was a baseline difference in their PF ratio. I don't know if you guys can see this, but in the success group, it was 126 compared to 76. So what we can surmise from this is people who failed on heated high flow were sicker to begin with, essentially. However, they did note that close to 70% of people that were treated with heated high flow were actually discharged without needing mechanical ventilation. So this was a little bit more reassuring. Our group here, or this is from Spain this time, and what they had done was they compared the early intubation strategy versus the heated high flow nasal cannula strategy. And what they found was that people who utilized heated high flow obviously had less ventilator days and quicker ICU discharge. And this became important when we were dealing with limited resources as well. So this is one of the first studies that gave credence to utilizing heated high flow in COVID-19. Now, this was a retrospective study that was published in the Blue Journal, and this was from France. And what they had done was they utilized, or they compared heated high flow patients to non-heated high flow patients, and the need for mechanical ventilation was less in heated high flow. So what we can surmise from this study is that it goes along with previously published data about hypoxic respiratory failure on how utilizing heated high flow can actually decrease your need for mechanical ventilation. And this can be applied to COVID-19 as well. All right. Any questions so far, guys? Okay. So now, I know early on during the pandemic, we were talking quite a lot about aerosolization of viral particles. There was groups that had actually taken a look at this earlier. Interestingly enough, what they found was that the utilization of heated high flow and the dispersal pattern of your aerosols really depended on how compliant your lungs are. Highly compliant lungs were able to aerosolize more. Severely diseased lungs were able to aerosolize less, and that's kind of intuitive as well. And what they found also was that ill-fitting cannulas tended to have a higher dispersal pattern rather than well-fitting cannulas. And interestingly enough, a regular nasal cannula had one of the highest dispersion patterns. So utilizing heated high flow in this scenario with patients with severe ARDS is actually less aerosolization than standard oxygen therapy. Another study that was published in China again, this was, I believe, 5 patients or so, and they wanted to see how far you're able to cough, or how far the dispersion pattern is if you're having a cough. And they found the difference to be about 0.5 meters or so, and that's kind of where the 6 feet apart comes from. 5 people. Don't laugh. Now, well, okay, this is 8 patients. Is that better? So this group took a look at the aerosolization of viral particles utilizing various modes of oxygen therapy. So they measured, so the way you interpret this, the white is baseline breathing. They're sitting there without anything on. And then we go up sequentially from 4 liters to 15 liters. And then we're on heated high flow. And the purple lines are using BiPAP. So the blue lines are heated high flow. Purple lines are non-invasive ventilation. What they found out was that the amount of aerosolization did not really depend on what flow rates or what kind of oxygen modality they were on. It was very patient specific on whether you generated aerosols or not. So having a blanket statement about the aerosolization of viral particles may not be super accurate. These were some studies done related to mask use during, or how a mask helps with coarse and fine particles. So the one on the left, this was done on influenza A. And what they found out was that there was about a 40% decrease using a mask in the amount of aerosolization of influenza A particles. Similarly, in 2020, they had taken a look at all respiratory viruses from a subset of patients in Hong Kong. And this included non-COVID coronaviruses because COVID was not a thing back then. And they found pretty significant decreases both in respiratory droplets and aerosol droplets using mask. So I just found that was interesting. So they work apparently. Now we have data to support that. Early on, there was a concern about utilizing heated high flow in terms of exposure to healthcare workers. And these were some of the published studies from early 2020, which basically said that there was no real healthcare exposures when utilizing adequate PPE in patients who were treated with heated high flow nasal cannula. Another thing that comes about is the utilization of prone positioning with heated high flow. This was a small subset of patients from China in which they compared heated high flow use along with heated high flow plus prone positioning use. And as you can see that there pretty significant increase in the PF ratio when prone positioning was utilized with using the same flow rates and the same FiO2. And this was a case report that was published from Canada. What you're looking at is PF ratios during or utilizing heated high flow, and the orange arrows indicate the times that the patient was prone. So you can see as after they prone, he has a nice spike of his PF ratio. He's back supine and that PF ratio drops. Now, after that last arrow, what happened for about 24-hour period was he had severe nasal congestion related to the use of heated high flow. And that's why you're not seeing the PF ratio increase even with proning. So something to consider when you have patients who are on heated high flow for a number of days is to make sure that they're not having any kind of nasal congestion, because that can kind of negate your oxygenation therapy. I told you the ROX index comes up about very frequently. So this group from Temple took a look at whether the ROX index can be utilized in COVID-19 patients. And what they found out was that any decrease in the ROX index after initiation of heated high flow was a bad prognostic sign for patients, regardless of if they improved the ROX index afterwards or not. So any drop during treatment therapy was more predictive of needing mechanical ventilation. So the way I see utilizing the ROX index would be a higher index of suspicion for those patients, essentially. So the surviving sepsis guidelines that were published specifically for COVID-19 patients does put heated high flow utilization right in the center of their algorithm if they're requiring more oxygenation supplementation. Now this is really interesting. This was published a couple weeks ago. So they were comparing helmet non-invasive ventilation to a traditional face mask BiPAP, and they also compared that to heated high flow. So on the left, what you're looking at is the force plots for helmet versus regular face mask. And what you're seeing here is that there is a decrease in the need for mechanical ventilation in the helmet group. And there was also a decrease in mortality as well for those same patients. Now, this data has to be interpreted with slight caution, as the majority of the analysis was dominated by one study. So not really sure where we're going to end up lying on this, but this is something that is being looked at right now. And when we look at the helmet versus heated high flow side, There's only 2 studies that they had utilized in their review. They found that utilizing helmet, non-invasive ventilation, did decrease the need for mechanical ventilation. However, no difference in mortality was noted. So something in the future that's up and coming. So we'll see where we end up on needing a helmet. So your patient kind of wants the helmet because it's kind of cool. He always wanted to be an astronaut, but here we are. He turned out to be a pulmonologist. So he, or the future me, finally accepts heated high flow for oxygenation support after your convincing literature search for him. So take-home points from this talk in terms of respiratory mechanics, utilizing heated high flow does reduce your respiratory rate, improves your PF ratio, and provides a little bit of PEEP. Clinically, it does reduce the need for intubation. No change in mortality that we know of so far. Can be used in a wide variety of patient populations for hypoxic failure. We made a mention of the ROX index and how we can utilize that. Consideration for post-extubation use. And in COVID-19, where we are able to use heated high flow for treatment of hypoxia, we do have some literature to support that as well. And that was it. Any questions, concerns, comments? Nothing. What's that? We kept them. Of course he does. What's up?